And hello, good to see everyone. It is Wednesday night. This of course means we're getting into KFP preparation. Hopefully your week's been good. A few IT troubles as we've kicked off tonight, but it wouldn't be a trial of a new stream and new technology without it. Hopefully you're doing well. I have prepared today a cough button for my now infamous cough that just doesn't seem to kick, which means hopefully you won't be hearing anything on the stream itself. How's that for timing? There we go. Had it ready and good to go. Now, for those that hung around at the end of the live stream last week, we did have a bit of a chat and decided to come up with a few topics that people wanted to have some teaching about today. And one of the things that did come up that I thought was particularly good to have a bit of focus on was Indigenous health. And so, of course, to kick things off then, I would like to start by acknowledgement of country. I begin today by acknowledging the LACGP people, the traditional custodians of the land on which I sit and stream from tonight, and I pay my respect to their elders, past, present, and of course coming. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. Now, for those that don't tune in regularly, it's not a acknowledgement that I tend to do for every single stream, and I wanted to also point out today that I'm acutely aware that I am a cis, white, Australian-born male, and I come from a place of profound privilege because of that. And so I think sometimes it's easy for these kinds of acknowledgements to come off as almost paying lip service and insincere. So it's not something that I think I do routinely, but it is something that I am considerate of. I do work in a rural community that has a large Aboriginal population, and so care of that population is something that I hold very near and dear to my heart and practice every single day in the clinic. Now, of course, it is something that if you're not familiar with, if you don't have a particularly large Indigenous or Aboriginal cohort in your practice, then it's something that you may not have much exposure or practice with. And I think coming into the exam, there is a particular focus, and it's one of the kind of guaranteed questions, so to speak. And so it is an area that I think it is worth knowing what are the peculiarities of treating different populations according to their specific needs. And the care of Aboriginal and Torres Strait Islander Australians is something that sadly we don't have a great track record with, and is something that I think we can really focus our efforts on. Of course, we are 10 days before the exam. Now, with this, I want you to be focusing in on, as we've already said, missed the button, doing as many practice questions as you possibly can in this last time before the exam. At the same time, as was highlighted through an interaction I had earlier on this week, don't burn yourself out. I know a lot of people do take a fair bit of time off around the exam to do this final little run in, and I would say that's fantastic if you have taken a couple of weeks off or a week off to really hit home before the exam. Don't forget to have breaks. You don't want to hit the exam completely burnt out, so make sure you schedule in fun activities, you do things you still enjoy, and you don't let this exam completely consume your life, as important as it is. Do make sure you're doing other things that give you joy and satisfaction, and as we'll talk about next week as well, do have time off. So actually, I always think it's a good idea to have the day before the exam or 2 days before the exam, your personal preference, where you do no study at all. Sounds blasphemous, I know. But the point is, at that point in time, you're not going to be making any sudden massive breakthroughs in terms of your study progression. So give yourself that little chance to breathe and go into the exam fresh and ready to go. Now, again, back to the focus of tonight. As was mentioned, we're going to have a bit of a focus on Aboriginal and Torres Strait Islander health, and if this isn't something that you feel particularly strong in your knowledge base, here are some resources I strongly recommend for those that don't have to type out all of this. I've actually put these links in the description for the video as well. So feel free to follow through and have a look at these resources. Of course, we are here tonight to practice some questions, and so let's put 2 minutes on the clock for the first question tonight. Your time starts now. All right, time is up, and let's go through to some answers. So, without saying too much, a question like this is pretty common in the actual exams. It's identifying what are the barriers for Aboriginal and Torres Strait Islander people from accessing healthcare, and this is a list that you'll see again and again. So, again, we'll go through next week what are the kind of common questions that seem to pop up year to year, bearing in mind there's several kind of core domains of general practice that they are always wanting to assess, and so having a good set of kind of default answers for questions like this will give you good results at the end of the day. Now, sadly, lots of things will actually get in the way of of giving Aboriginal and Torres Strait Islander people access to healthcare. First thing, of course, being services not being readily available in their area. Tied into that a little bit is the field of geographic isolation. So often there's rural or particularly remote communities where it doesn't make financial sense or viability in terms of opening services, and so there is some interplay into there. Likewise, there can be a lack of available transport, particularly as you go more and more remote. Access to public transport can be almost non-existent, and it may be quite difficult for people to access private transportation as well. In very remote communities, where there's often outreach clinics that are actually taking healthcare to these kinds of populations to try and close these gaps, so to speak. Now, of course, the world being what it is, there is high financial costs, and tied into that as well will probably be grouped together for similar reasons would be high unemployment rates in Aboriginal and Torres Strait Islander people. So any answer that's acknowledging the financial barrier that's preventing people from accessing healthcare is going to get you a mark there. Tied into that, but I think would be a separate point, would be things like lower socioeconomic status, and again grouped together likely would be housing instability. And this can be not just the fact that it can be difficult to obtain housing, but in particularly rural Aboriginal and Torres Strait Islander communities, it's not uncommon for people not to have any kind of fixed home address, but rather to be living amongst several properties of relatives, friends, family, different people in their community with that kind of more shared housing mindset. Long wait times, often conflicting with the cultural expectations of different communities. Setting appointments may not work for a lot of Aboriginal and Torres Strait Islander communities, as well as a general poor availability of culturally safe or responsive health services. And that's a nice way of saying we do have a problem with racism in Australia. Anyone that's worked in this country is just well aware of it. I am sure you are, and it's a sad fact that we have to acknowledge. And I think it's important to acknowledge because that's the only way we're actually going to improve things. As well, we do unfortunately have poor health literacy in a lot of these populations, which means they may not necessarily be aware, one, what's wrong, or two, that they need to seek help, three, that there is even help available. And so there are a lot of programs and packages that are actually aimed at that in particular, and that might be relevant for answers later on. Just something to follow in the back of the head. So we do have some answers here, and as to me, you've put in wonderfully. We do have that geographical isolation tick. Systemic racism, I think that's a bit more of a to-the-point way of putting in the poor previous experiences with services or culturally safe. I think you'd get those ticks there. Cultural practice not being welcomed in another tribe's area could be a little bit risky because there are some areas where that may be the case, but I think that would probably be in the minor. I would probably look for other answers on that one. Financial hardship, though, definite tick. And language barrier, yes, definitely a problem, and one that should probably be on this list as well, so very well done there. All right, okay, we have more questions coming up, of course, so let's get 2 minutes on the clock, and of course your time starts now. All right, so time is up. And again, this is another one of those common questions that you do see pop up time and time again. And so some of the important things would be to actually acknowledge the patient's opinion, and tied in with that as well, explore what their concerns actually are. So it's validating their thoughts and their feeling. Addressing fears or misconceptions, and there could be potential overlap here between some of the other answers, but I think as long as you're acknowledging that it is worth trying to express good things here, and probably the one that would overlap with the most on this one here would be to highlight examples of culturally safe and respectful care if it's from the hospital, going ahead a little bit, but still on a lot of rubrics I've seen would be counting as a point. Tied into any time where we're talking about patients making informed consent would be ensuring that they understand the potential repercussions of not attending the hospital, because sometimes people may not realise quite how unwell they are, and so letting them know, hey, look, this is actually something that's quite dangerous to be trying to manage in the community may be enough to kind of tip people over. Probably not in this case, but still would definitely be worth a mark on the exam. Then we start looking at, well, what are our kind of external support structures and support networks to try and tap into. And one of the important things here, of course, is with permission. You need to be obtaining consent from the patient to be discussing their healthcare to bring other people on board. So with permission, engage the patient's family. With permission, engage community elders. With permission, engaging Aboriginal hospital liaison officers. And they do have different titles depending on where you work. So anything that's kind of in that vein is going to get you the marks, but it's probably worthwhile, if you aren't familiar, find out what your local hospital terminology is, as that'll make following up referrals in the future a bit easier for you. Likewise, we've already acknowledged that transport is an issue, so actually taking that stress away from them, arranging appropriate transport, which tied in with that would be use ambulance to provide transport to the hospital. And of course, as we've already said, highlight those examples of culturally safe and respectful care from the hospital to show that it may not be as bad as he necessarily fears. So again, to me, fantastic, involving the Aboriginal liaison officer, involving family members with patient consent. Excellent gold star for adding the consent line in there, as we said, vitally important. Helping organise transport, beautiful. Education on potentially lethal harms of non-attenders, beautiful. And longer appointment. You'd probably be wanting to follow that one up very, very carefully. Sadly, I don't think that last one would probably get you a mark in the exam. All right, of course, we have more questions coming up. So let's get another 2 minutes on the clock, and your time starts now. All right, time is up. And this is one of those questions that I think could muck a lot of people up. I think knowing what our billing criteria are is an important part of what we do day to day. Yeah, in reality, we're going to look it up. We're not going to try and take a punt and hope we got it right. We are going to be checking those eligibility criteria before doing anything. But for these exams, we should be displaying that we know what these kinds of criteria are in our what should be day-to-day practice. And so, of course, the criteria here is that the patient must self-identify as Aboriginal or Torres Strait Islander. And important to note, and you'll find this again and again when dealing with topics like this, it's a self-identified. There doesn't need to be any kind of evidence or family trees to go back through. The patient just has to self-identify, and that is more than sufficient. The second criteria is, of course, that the patient will have setbacks in preventing or managing their condition if they don't take the medicine. So there needs to be that element of financial hardship or inability to otherwise continue or maintain this medication without assistance. Next thing is that they are unlikely to keep up their treatment without help with the cost. So this is coming more into that maintenance side of it. And, of course, that the patient is enrolled with Medicare. True of all PBS medications, the patient needs to be in the system, so to speak, for this to go through. And top marks there. Well done. All right. Now, in case answers are coming through a little bit late, do make sure if you're on the live stream tonight that you have a look at the little red trace down the bottom. Make sure it's all the way across. You're up to date with the live stream as much as possible. There's been a couple of buffing errors tonight. I do apologise. So just to make sure you are kind of getting the questions as they come through, answering as the clock ends. Make sure you are live with me. Of course, we've got more cases. So let's get 2 minutes on the clock, and your time starts now. Ah, poor little Johnny. So, part of this question also implies you know a little bit about the kind of infections that Indigenous communities are potentially susceptible to, because unfortunately there is a disproportionate amount of things like acute post-streptococcal glomerulonephritis. I can never say that. I'm just going to say GN from here on. Please don't hate me for it. And look, as you've got in there, SP, post-strep GN and nephrotic syndrome are the two big ticket items here that I think most people would want to be seeing in your answers. Time with that as well to me. Well done. Post-strep GN. Rheumatic fever will come back to at the end. Of course, a couple of other things that you could consider here would be an IgA nephropathy, lupus nephritis, significantly less likely. Minimal change disease, yeah, I wouldn't be convinced with the blood pressure being elevated. You wouldn't expect that with minimal change disease, but all things you would be keeping in the back of your mind. Okay, now, we'll move on to the next question, of course. So let's get 2 minutes on the clock and your time starts now. All right, time is up, and here the answers we would have here, as you've put in rather nicely. A, urinalysis with microscopy. We're trying to confirm those urinary findings there, checking for hemoglobin in the blood, for example. UEC to directly assess our renal function. Anti-streptolysin O titer. This is to confirm if we're looking at a strep infection, obviously. Serum C3 levels. So serum C3 would be expected to be low in the post-infectious GN phase. I'm not going to say that word. I can't do it. I'm sorry. You could do a C4 level as well if you want to be really thorough, which you would expect to be normal in this setting. And of course, the other thing here would be your serum anti-DNase B level as well, which again would really lock in that we are looking at a post-strep GN. Now, some of the things I'm going to be a little bit mean for here as well is I don't think a J answer here, the complete blood count or FBE, in terms of confirming the most likely diagnosis, I don't think it would massively change the confirmation of the diagnosis. Would you do it? Hell yeah. But this is where we fall into that trap of reading the question, and really we want to confirm the diagnosis. In the 1 month period after the sore throat, we're probably not going to expect to see elevated white cells or anything more sinister there. So best bang for buck, you're going to get answers elsewhere. Likewise with G, we are 1 month post-infectious period. There's no other kind of symptoms of infection there. I intentionally gave it a normal... a normal temperature and otherwise relatively normal vital signs. Of course, we have thrown in a bit of high blood pressure there as well. Could that be relevant? Maybe. Let's find out. All right. Next question. Let's get 2 minutes on the clock, and your time starts now. Should we say now? time is up, and Demir, you called it from the get-go. You could see where this was heading, and of course, rheumatic fever is something that we need to be considering when dealing with, particularly remote or rural Aboriginal or Torres Strait Islander populations. And so this is taken from the therapeutic guidelines when looking at sore throat, and really what we're caring about is those streptococcal infections. The risk factors that would place someone at increased risk, or high risk rather, of a rheumatic fever would be a Aboriginal or Torres Strait Islander under the age of 40, so ticking those boxes there, living in a rural or remote area, living in a household affected by overcrowding, experiencing socioeconomic disadvantage, history of acute rheumatic fever or rheumatic heart disease, and that would not get your mark here because there's no history of that there. And as you've both put in here, history of streptococcal GN or confirmed streptococcal infection, interestingly enough, that infection on its own, because there's lots of forms of those streptococcal infections, that in and of itself doesn't actually place you at increased risk. Sounds crazy, I know, but it's in there. Now, one of the things that would be important here would be part of a family or household in which a member has had a recent history of acute rheumatic fever or rheumatic heart disease. Pardon me. So those are the answers I'd be putting into here. To be honest, if I was going through and marking the exams, that history of a confirmed streptococcal infection, if you can confirm the strain in there, I think I'd be giving that mark because in reality that is going to be putting them at that increased risk there. And so I think as long as you're being specific as you were, I think you probably would get over the line. But if we're going by kind of what's written on the page, these are the answers that are provided. Now, we still have... and sorry, I'll just pop up on here because Demir, you've just, let's go last slide. You've just popped on there very appropriately. You assume his ASOT 90 DNAs came back positive. Yeah, and that's what I'm saying. Like in this kind of setting, I think you probably would get over that line, but it's not listed in the official things here. Again, I'd totally be giving you that mark in the exam. Cool. Moving on to the next case, of course. Let's get 2 minutes on the clock, and your time starts now. All right, time is up, and let's get through some answers. So lots of things that can be done, and I think probably one of the most important things is to actually make sure that staff have completed some form of cultural awareness training. We do hold a lot of unconscious and unintentional bias, and I think one of the easiest ways to start picking on that is to actually go through some cultural awareness training. And I think, funnily enough, it's often the people that kind of say, oh, we don't need to do that, that probably need it the most. Now, of course, ensure the practice environment is welcoming. This sounds like a silly thing, but having a space that's warm, that's caring, and looks pleasant is something that goes a long, long way. Placing flags or art in the clinic, so having, and that should specify, sorry, that Aboriginal or Torres Strait Islander flags or art in the clinic. Developing educational materials, pamphlets, posters, flyers, those kinds of things that highlight Aboriginal and Torres Strait Islander people's health, and of course engaging with local elders to explore what the community needs. That way that can spread word through the community as well as inform the clinic what they actually need to be doing. Because it's nice to say that we want to improve health, but without knowing what the actual troubles are that you're supposedly targeting, I don't think you're going to get very far. So we've got some great answers through here with Demir, fantastic. So displaying the cultural imagery, and if you ever attempted to put the EG flag, feel free to just put flag. Try not to, but starting again, the risk you're running there is overcoding. So they might say that you're trying to give two answers there, and so you're probably better off just hedging that and putting one or the other. Ensure the practice is enrolled with the practice incentive program. Fantastic. Again, if I'm being really, really picky, avoid the abbreviations, but I know in real life you'd be handwriting that out. And again, providing cultural safety training for staff. Well done. SB, I'm going to be really mean for a second and say that you've got photo of community elder, fantastic, and in practice these are all things you definitely would do. Aboriginal Torres Strait Islander flag in the waiting room, Aboriginal art in the waiting room, all very, very valid answers, but you've fallen for a trap of not diversifying answers enough. And so really all of those things kind of tie into the same kind of group, as you just said in the chat there. And so I think while they're all good things to do, it's kind of different ways of saying the same thing. And it's frustrating as well because I know that the answers here show that ensure the practice environment is welcoming probably does have a lot of overlap with things like place flags or art in the clinic, but they do target things slightly differently. Otherwise, though, all sensible things. And again, this is one of those areas where I don't think it's people's clinical knowledge that mucks them up in the exam. It's knowing the game of the exam is as much that gets you through as knowing the right answers. So the AKT is aimed at testing your clinical knowledge. The KFP really is about the game. Hate to say it. It is what it is. That's why I do these sessions. Of course, we've got more questions. So let's get 2 minutes on the clock and your time starts now. No, it doesn't, because I'm having IT issues tonight. Let's try that again. Let's get 2 minutes on the clock and your time starts now. All right, so time is up. And as I can see one answer in there, gosh, what a question. And I know that looking at it, you might say, oh, come on, that's not going to be in the exam. Guess what? Things that impact clinical practice, questions like this, the more kind of admin side of things, it's fair game. And questions like this have been in actual exams. And again, having a few of these kind of structured approaches to work out, well, okay, think about it from square one. What would we do if a new patient were to come in? How would we pick that up? That kind of thinking, that kind of process can come in handy for a whole bunch of different scenarios. And so, as has been readily identified very appropriately, ask the patient directly. Like most things in medicine, if you don't look, you don't find. And the easiest way is to say, hey, does this apply to you? And you'll be surprised sometimes. Things like gender diversity, for example, or sexual practices, things that you may feel a little bit uncomfortable doing, can make a massive difference in terms of patient care. So again, don't look, don't find, just do it. Ensure there is documentation in the medical record of Aboriginal or Torres Strait Islander status. This can be in the registration forms, as has been put in by SP, as well as in the software as well. There should be a space for it, and it should be flagged that if it's empty or not filled, fill it. Train your staff to be confident about explaining to patients the reasons for asking. Sometimes if staff are asked to ask potentially confronting questions, have a script prepared to actually express what that is can be incredibly useful. Encourage open communication for self-identification during patient interactions, and display educational posters in the waiting area to promote the importance of cultural identification. Where did these answers come from? From the 5 Steps Towards Excellence in Aboriginal and Torres Strait Islander Healthcare from RACGP. So, yep, hate to say, this is fair game. All right, of course, we have another question here. So let's get 2 minutes on the clock, and your time starts now. All right, time is up and answers are up as well. Now, if you're not in an area or don't have a lot of patients that identify as Aboriginal or Torres Strait Islander, this is something you may have never actually come across. And that's why, again, I'm really keen to go through it tonight. And again, those resources I had at the start of the show and in the description link through to some of this stuff as well. So there is a specific Indigenous health assessment item that can be done every 9 months. Most health assessments are locked in for every 12 months because we know there is inequity in healthcare towards Aboriginal and Torres Strait Islanders. There is a higher frequency that is permitted by MBS to bill that item number. And set aside some time because it is rigorous. And I would encourage you to follow through to the resources for people to support page. because it's actually very, very extensive. They've got some absolutely brilliant templates there. They're in locked PDFs, so you can't just copy and paste them, unfortunately. But I will often print them out, fill them out by hand, and then scan them into the records. I would have loved an electronic solution, but there we go. There are some ones you can load into things like best practice, but it's not the same. So you won't need to know for the exam, but I thought I'd pop it into here for your own knowledge. This is MBS item 715. Now, if you think to all of your care plans and preventative health kind of measures, there's always that initial part and then that follow-up. And so there is the follow-up provided by an Aboriginal or Torres Strait Islander health practitioner or practice nurse on behalf of a GP, and by an Aboriginal or Torres Strait Islander health practitioner or Aboriginal and Torres Strait Islander health worker with referral from a GP. So these are other people in the practice that can provide those ongoing services, and they are up to 10 follow-ups per year. Tied in as well is a health heart assessment. This is item number 699. You get one annually. And the tricky thing with this is I didn't want to put in your standard kind of chronic disease management plan, which wouldn't be a more preventive health screening kind of thing. There's no mention of kind of chronic diseases here. But I do want to flag, though, that Aboriginal and Torres Strait Islanders do get an additional 5 EPC referral visits on those plans compared to non-Aboriginal or Torres Strait Islander people. So something really, really good to keep in mind. And again, it's about trying to address that inequity in healthcare for those populations. So as you've got here, a cardiac health check, fantastic. Sexual health check, I don't think you would get the item number for that one put through. And visual acuity testing, good point. Possibly. I think you would probably be better off putting the Indigenous health assessment item number, though, as a safer bet. 715, fantastic. And remembering as well, these are clinicians marking the exam, so if they see 715 there, they're going to say, yeah, Butte, you know exactly what you're on about there. Heart health check, fantastic. And GP management plan, yeah, 2 out of 3 is good enough. I'd be happy with that one too. All right. So that was our last question of the last case for tonight. Well done for sticking through for another week. Great to see all those answers coming through in the chat. Again, the more you practice, the better you're going to be. I know we're typing it out here tonight, but I really do hope as well that you are practicing handwriting out these answers when you're doing study on your own, because one thing that often strikes people in the exam itself is hand cramping and just not being able to sustain handwriting for so many hours if it's not something that you spend a bit of time building up for. So again, I'm still doing these sessions before the exams. There'll be one more next week, and the thing that I wanted to focus on next week was going to be focusing in on what are those common type questions that seem to appear again and again and again. Having sat before finally passing the KFP myself 3 times, I have a unique insight into the things that do seem to pop up again and again. So tune in for that or jump into the feeds later on. I'm going to try and get a bit of a concise overview of all of the common question fields, and then we'll go through some of the specific examples as well. But again, one of the common domains you will see in the exam are questions around Indigenous health, and there often is that element of what are those barriers, how can they be overcome, what are the things we can do in practice to actually change the way we address Aboriginal and Torres Strait Islander health. So thank you very much for the thank you, greatly appreciated. I'm super keen to just keep building up these resources. I know what a hard time I had getting through the exam before everything just started clicking and I realised where I was going wrong, and I want to try and make sure that there's free resources available for people out there as well. Now, of course, if you've got any questions, comments, queries, feel free to throw it in the chat here or throw it into the comments on the videos as they come through. We've had a little explosion in subscribers, which is always very welcome to see in the last week or two. I like to think that it's because I started making a few shorts, which I'm sure most people do not care at all about. But I think it's also the fact that we are coming up to the exam, and so there's probably just more people searching for this kind of stuff. Spread the word, though. Let other people know. Again, seeing feedback, seeing comments, seeing views lets me know that people are finding this helpful, and ultimately that's what lets me know I'm doing the right thing by continuing to produce this. If you do disagree with any answers, please throw it in the comments, because I want to make sure my information is as accurate as possible as well. And I do try and take stuff that I think could be ambiguous or uncertain to the college and try and get feedback from there. We'll see how that all goes. I won't hold you up too much more tonight. Thank you guys for joining in. We'll finish it up here. And of course, I really look forward to catching you all at next week's live stream. This cough, man. If only there was a good GP around here I could see to sort me out. And of course, I hope you have a really lovely week. Until then, take care, guys.